Okay, so the title of my talk, I was given this title, The Subtleties of Uterine Sonography. And so what we're going to talk about is basically I've picked 3 topics. So we'll talk about adenomyosis, and I know that John Pellarito addressed it, but, we'll show different cases, how to recognize this common condition and potential pitfalls. We'll talk a little bit about uterine fibroids when they cause problems. So I have some selected cases where, they may be helpful to have some subtle tips. We'll talk about the very large uterus and what does that mean? How should you work it up? And finally, we'll talk about beware of vascularity endometrium, particularly I think it's helpful in postmenopausal women where you're always concerned about endometrial cancer. And so before I start, when we talk about, it's always important to look at the indications, and many of the uterine abnormality can be found just incidentally. But, the 2 main symptoms that are associated with uterine abnormalities, of course, a big one is vaginal bleeding, abnormal, either menorrhagia or menometrorrhagia, or also sometimes mass effect if you have a very large uterus. So these are all important things to keep in mind. So we'll start with adenomyosis. And basically what it is the presence of endometrial glands that have migrated into the myometrium. And they undergo cyclical bleeding, and then that produces changes in the myometrium. So it's a very, very common condition that before we paid attention to subtle transvaginal findings on ultrasound, we didn't really recognize it. And this is one of the typical things where the sonographer would write ill-defined fibroids. So it's supposedly more common in women who also has endometriosis. And there are 2 theories, a trauma-induced theory where there's migration of the endometrial gland through the basilis layer into the junctional zone, or the congenital where there are rests that get then transformed during life. So both adenomyosis and myomas are very, very common conditions. So I think if we go back to the pathology, it's important to keep that in mind because it will help you kind of understand the sonographic findings. So in adenomyosis, basically you have endometrial gland and stroma in the myometrium. And there's also hyperplasia. So you have these endometrial glands, and there's also secondary hypertrophy and hyperplasia of the adjacent myometrium, probably because of cyclical bleeding. So it is typically a diffuse condition. It can be focal in the myometrium, but it's focal. It's also ill-defined. As opposed to myomas or fibroids, which are benign smooth muscle tumor, which contains a variable amount of smooth muscle and fibrous tissue, and they are surrounded by a pseudocapsule. So they will be typically well-defined masses, and their growth is hormonal dependent. So in adenomyosis, the risk factors are increasing age, multiparity, pregnancy termination, increased estrogen exposure. Many of these women can be asymptomatic. However, many of them have, especially if it's severe adenomyosis, they can have menorrhagia. They can have pelvic pressure because uterus becomes kind of enlarged and boggy. And some patients have dysmenorrhea, and there's question whether it affects fertility. So again, when we look at the sonographic findings, we're going to look at the direct sonographic findings showing the distended endometrial glands within the myometrium, and then we'll also look at the myometrial changes. So what are these? So the first thing, and that's a more direct sign of adenomyosis, is to see these ectopic endometrial glands within the myometrium. So they can look like echogenic nodules or striation, kind of echogenic striation extending from the myometrium from the endometrium into the myometrium, or you can have myometrial cysts. There's also lollipop diverticuli with cystic diverticuli extending from the endometrium into the myometrium. And sometimes you'll just see, and that's what, it's easier to see on MR, the thickened junctional, hypoechoic junctional zone. Now, the smooth muscle changes result in either asymmetric myometrial thickening, heterogeneous appearance of the myometrium. These lesions always have an ill-defined border, so you can't really, circle it with precision. And then, as John showed on Monday, you can have this coarse echotexture, the Venetian blind appearance, or hypoechoic kind of striation throughout the myometrium. And then something that you can use maybe in the adjunct is the vascular changes. Oftentimes, these lesions have increased vascularity, and they have penetrating myometrial vessels. So a technical tip, I always like to see a transabdominal ultrasound because it'll give me a better idea of the size of the uterus and whether it's diffusely enlarged as it adenomyosis, or in this case is that a focal fibroid, because this is relatively well defined. If you want to look at the junctional zone, which is this hypoechoic area between the endometrium and the myometrium, which is a little bit more echogenic than the junctional zone, I think coronal reconstruction, if you can do it, is really, really helpful. And finally, to pick up subtle changes of adenomyosis, I think looking at cineclips is critical. Otherwise, you're going to miss some of these cases. And so we require routine cineclips through the uterus on all our endovaginal ultrasounds. So these are examples of direct visualization of the endometrial glands within the myometrium. So they can be cystic. Sometimes they have little echogenic borders, or they can have these echogenic nodules within the myometrium. Notice also that oftentimes in advanced adenomyosis, the borders of the endometrium are going to be ill-defined because you have all these glands kind of extending from the endometrium into the myometrium. And you can see this nicely on the 3D, where you can see this finger-like echogenic projection into the myometrium extending from the endometrium. And again, cineclips are very helpful. These just show you the combination of all the findings. You see the Venetian blind appearance, you see the echogenic nodule, you see the cystic changes, and I think you can better appreciate on the cineclips that this is really such a diffuse process. Now, the smooth muscle changes on the front, often these times are in combination, right? I mean, it's not just one or the other. Transabdominally, what you're going to see is a globularly enlarged uterus. And then on the vaginal scan, you pick up better that there is this Venetian blind. This is this kind of diffuse hypoechoic striation coming from the myometrium. And this is just the MR confirming that this patient had adenomyosis. This was a 45-year-old with pelvic pain. And I think if the patient, if they're going to intervene in this patient, I think having MR confirmation is really helpful because MR is more sensitive to detect subtle changes than ultrasound. Again, another example, again, showing the extensive striation, the cystic changes, and the MR correlating marked thickening of the junctional zone with all the cystic changes. Now, this is a more subtle case. This patient had menorrhagia. That was the indication. And I think on the still images, it's hard to see that anything abnormal. But if you look at the cineclips, again, you're going to pick up subtle subendometrial cystic changes, and you're going to pick up, again, this Venetian blind appearance. And this was confirmed that she had adenomyosis on the MRI. Another subtle case here, you don't even see the endometrium. And if this patient had vaginal bleeding, I would probably feel better if they sampled the endometrium because you can't even recognize it. But if you look at the scan, there is asymmetric heterogeneous appearance, asymmetric thickening and heterogeneous appearance of the myometrium with this. You don't really see that many striations, but when we put the color, you see that there's penetrating vessels and increased vascularity right in this area, which again is suggesting that this could be focal, a more focal appearance of adenomyosis, again confirmed on the MRI. Vascularity is also helpful if you're trying to differentiate a focal adenomyoma from a fibroid or myoma. Okay, so here's the myoma. It's hypoechoic, doesn't have that much shadowing, but it has this peripheral vascularity, and it's well defined. This is perhaps a slightly less well-defined lesion. There are some cystic changes, a little bit more heterogeneous, but when you look at the vascularity, you see these penetrating vessels. So we suggested this was a focal adenomyosis, and this was confirmed on the MR. Now, I just want to say a brief word about tamoxifen and the uterus, because you see this very, very commonly. All of us see it in our practice. So this is a non-steroidal anti-estrogen compound that's used in the treatment of estrogen-dependent breast cancer. And while it is an estrogen antagonist in the breast, it's actually an estrogen agonist on the endometrium. And these patients have an increased risk of hyperplasia, polyps, and perhaps a small increased risk in endometrial cancer. That's a little bit controversial. But many of these patients will have abnormality on the ultrasound. They can have a thick endometrium. They can have cystic changes. They can also have subendometrial cysts. And certainly it's always controversial, when do you start sampling these patients, or if patients has vaginal bleeding, that's an indication. But also if you see an increased thickness over time, if you're monitoring the patient over time, that probably should trigger histological sampling as well, because of the small potential risk of endometrial cancer. The other thing it does, it can reactivate adenomyosis and also endometriosis in these postmenopausal women. So that's something to keep in mind. And this was a 54-year-old postmenopausal asymptomatic woman who had this thickened endometrium, 1.4, I think, with some cystic changes. But again, if you look at the video clips, you can see that the cystic changes are not limited to the endometrium, but also extend into the myometrium. It's very likely reactivation of adenomyosis. The other thing, of course, that tamoxifen can do is lead to endometrial polyp. And occasionally, these polyps are very big. They're giants if they're over 3 centimeters. So this is a very large, thickened endometrium with multiple cystic changes everywhere. There is a little bit of increased vascularity, but if I see a lot of cystic changes, a little bit reassuring that this is going to be a polyp. But of course, at this large size, and here's the MR showing the same thing, very large polyp with mass with cystic changes, then of course you're going to have to take it out, because there could be a small focus of cancer. And this turned out to be a benign giant endometrial polyp at pathology. This is a rare case. So this is cystic adenomyoma, which is basically the presence of a cyst lined with endometrial gland and stroma within the myometrium. And these undergo cyclical bleeding every time the patient has menstrual cycle. So it looks kind of like an endometrioma in the myometrium. This patient had a long history of pelvic pain. We confirmed that diagnosis. That's a very old case by aspiration. And this is a very rare condition. Basically, the case report in the literature. Now, one of the things that's really important to consider is this adenomyosis, or is it deep pelvic endometriosis? Because the implications are very different, right? So when I think about adenomyosis, which is this case here, it is growing from the endometrium into the myometrium. When you think about deep pelvic endometriosis, it's basically also, you can think about it as external adenomyosis, when the adenomyosis and the endometrial glands grow from outside the pelvis into the myometrium. So oftentimes in this patient, the junctional zone is actually spared. Oftentimes this patient will have more debilitating symptoms of chronic pelvic pain. Can be very, very debilitating. This patient also has, so if you look at it here, it's a hypoechoic ill-defined lesion again, but it's growing from the outside in, and the junctional zone is spared. This patient also had a little endometrioma. That's always helpful for the diagnosis. Another example, the uterus can be retroflexed or antiflexed because of the severe adhesions and tissue kind of tethering the uterus. Again, external adenomyosis, this was a retroverted uterus, and you can see there's a lot of soft tissue also surrounding the uterus and in the rectovaginal pouch. And this is actually confirmed on the MR. There's extensive adenomyosis, but there is also low signal intensity lesion in the rectovaginal pouch that confirms that this is deep pelvic endometriosis. Okay, so now glioma, when do they matter? So they are very, very common. They present mass effect. They can have deformity of the endometrial stripe if they are submucosal. If they are very large, I think it's very helpful to do a transabdominal ultrasound so you have the extent of the fibroid. And really, when you do this, insist that your sonographer go above the fundus. Okay, you want to make sure that they give you an image above the fundus, because I've seen big pedunculated subserosal fibroids that are above the fundus that have been missed, and that's really kind of embarrassing if you see that you've missed a 5 or 8 centimeter submucosal fibroid. So very important to go above the uterus. And so, as I showed you before, these are masses with well-defined borders because they have a pseudocapsule. They're usually hypoechoic. They may have a whorled appearance, and they may have shadowing, not just because they're calcified, but just because there is the interface between the stroma and the connective tissue. So they'll have this kind of streaky shadowing, but it is going to not be diffuse in the myometrium, but just coming from this well-defined hypoechoic mass. And in terms of vascular changes, you'll have vessel displacement. And it's really, and I'll show an example of looking at bridging vessels going from the uterus into a pedunculated myoma, because that's a helpful diagnostic sign. So again, just a typical appearance. Many of them are detected incidentally. Well-defined hypoechoic lesion, somewhat heterogeneous with this streaky shadowing, which is much better seen on the vaginal ultrasound because of higher resolution. So real estate is everything, and so we're going to focus on some of the myomas that are going to cause problems. So let's talk first about submucosal myoma. They're not that common, but they are the one who will cause symptoms, right? Because a patient may have fertility issue or may have vaginal bleeding. And so they will appear as a hypoechoic mass. Again, the streaky shadowing coming from the mass is very, very helpful to determine that this is indeed a myoma. So what you want to describe is whether it's less than 50% or more than 50% intramural. If it's intracavitary like this one, where the 3D imaging is really helpful, showing it's predominantly intracavitary, that's also an important information to give the referring clinicians, because in this patient who had menorrhagia, they can just do hysteroscopic removal. So it's a much easier approach. Now, some of these will present into your emergency room with heavy vaginal bleeding. This was a 37-year-old woman, very heavy vaginal bleeding, several pads a day, anemic. And what happened in this patient, she had a submucosal myoma that eventually, due to uterine contraction, prolapsed into the cervix. So the images are not always very pretty because you see this mass in the pelvis, you see the bridging vessels coming from the endometrium here. And we, in this case, just to kind of try to define this mass a little bit better, we also try to do translabial ultrasound where you just use a curvilinear transducer, put it on the labia. And I think it shows a little bit better that this is a well-defined mass kind of in the cervix, again, with this streaky shadowing. And she had, emergent hysteroscopic resection. Now, are we dealing with a submucosal myoma, or we're dealing with an endometrial polyp? And sometimes, if you just look at the transvaginal itself, it's difficult. True, myoma tend to be more hypoechoic. Polyps should be echogenic, but it's really hard to tell. So if in these cases, I think doing saline installation of saline and doing an ultrasound is very, very helpful, because you see that this myoma here is hypoechoic. Maybe you see the shadowing a little bit better, and importantly, it has a very broad attachment to the myometrium. Versus these polyps, you see perhaps a little bit better. They're echogenic. They're in fact multiple, and they are predominantly intracavitary. And the other thing that's really helpful with endometrial polyp is the vascular stalk. If you can demonstrate a vascular stalk leading into the endometrial mass, it's again a very good sign for endometrial polyps. So this is another problem case. You have a patient, so they were feeling a mass on physical exam, and you see here's the uterus, and you see this big mass here. And the mass was so big that it was a little bit difficult. We had to struggle to find the ovary separate from it. The first thing you're going to do is to determine if this is an ovarian mass or a pedunculated myoma, try to find the ovaries. The other thing that can be helpful is to see those bridging vessels going from the uterus to the myoma. That's also a very good indication that this is a pedunculated myoma. And here again is the MR confirming this patient had multiple myomas, including this one, which was exophytic. Another example of a small exophytic myoma, you can nicely see the bridging vessels going into the lesion. And the other thing you can do, if you see the ovary, you want to try to push on this lesion to see if it moves separate from the ovary. And we convinced ourselves that this was separate from the ovary. And this was also confirmed to be a small pedunculated myoma. Now, myoma do grow over time, or they're estrogen dependent, and growth can be associated with pregnancy, aneuploid cycle, also tamoxifen, as we discussed before. They can grow during the 5th decade of life. So women between 40 and 50, typically, they had a fibroid when they were 30 and it will grow. And the rate of growth really doesn't correlate with risk of leiomyosarcoma. But of course, if you have a rapid growth of the patient start bleeding, new symptoms, then definitely these patients needs to have an MRI for further evaluation. And they should regress after menopause. So another cause of growth is torsion. So this patient presented with acute abdominal pain. This was the ultrasound here, very large pedunculated myoma. We had an ultrasound from a year ago where it was 3 centimeters. Now it's 9 centimeters. She had symptoms, and we just kind of worried. We weren't sure exactly what was going on. We thought about torsion, but we weren't sure. On CT, you can see, because you couldn't get an emergency MR, so you have a poor enhancement of this myoma, and this turned out that she had torus benign myoma with degeneration and necrosis. So now let's talk about a patient who has very large uterus. So we're not talking 10 centimeter, we're talking 15 centimeter. But I mean, I don't have any numbers, but when you recognize a very large uterus when you see it. So the first thing is it's best imaged transabdominally. So you need to have a big field of view. And so what's your differential? Well, it could be multiple myomas, right? It could be leiomyomatosis or metastatic leiomyoma, very rare condition. And of course, what we always are concerned about is malignant tumors of the myometrium, uterine sarcomas, which are rare, but they have a very bad prognosis. So you want to try to at least pick up and send these patients for further imaging. And then very rarely metastasis and lymphoma. So here's an example just of a myomatous uterus. It goes up to the umbilicals or above. Here's the uterus itself, and there's a large fibroid myoma in the cul-de-sac and then multiple. That's an easy diagnosis. But what about this patient? So first of all, she's 68. She has a very large uterus, 18 centimeter or so, and she has vaginal bleeding. And they first did a blind biopsy, and the biopsy was negative. So if you look at this right away, it's too big. And you really have to be concerned about leiomyosarcoma or another malignant tumor in the uterus. She also had lymphadenopathy. So of course, then, that clinches the diagnosis. And it was a high-grade sarcoma. This is another patient, again, postmenopausal bleeding with very large heterogeneous uterus. The vaginal ultrasound was useless. We couldn't find the endometrium at all. And so we suspected it was a uterine cancer. We didn't know what type, which raised the possibility of sarcoma. And this was a carcinosarcoma, which I think originates from the endometrium, was a very aggressive, non-estrogen dependent endometrial cancer. This is just a CT, again, at the time of staging, showing a very heterogeneous necrotic mass within the uterus. Uterine metastasis, very, very uncommon. So I'll just show you the only example that I've come across. This was a patient who had metastatic breast cancer. So she had a very large heterogeneous uterus on CT, which was done, as a follow-up. And on the ultrasound, large uterus, very heterogeneous with increased vascularity. And then finally, just an unusual lesion in the uterus. It's mostly a fatty lesion. So it's very rare. I've only seen 2 or 3 cases. So very echogenic with ill-defined shadowing. Looks kind of a cystic teratoma, but it's in the uterus. And it's very easy to diagnose on CT because it's mostly a fatty replaced mass. Typically, it's found in patients who are peri or early postmenopausal, and oftentimes they're asymptomatic. To finish, I want to say a few words about the endometrium and how I use abnormal endometrial vascularity, and so particularly in the patient who have postmenopausal bleeding. So this was a very large series looking at women with abnormal vaginal bleeding and what they found. Now, the caveat is that the majority of these women were premenopausal. About a third was postmenopausal. So probably if you did only postmenopausal women, the pathology would be different. But the bottom line is that what we are worried about is endometrial cancer, right? And it's only about, in this series, 6.7%. So other pathology are more common in patients who have vaginal bleeding. Atrophy, particularly in postmenopausal women, hyperplasia, and polyps. So how do we differentiate that? And so vaginal ultrasound plays a critical role. And the first thing you want to do is measure the endometrium, right? So it's important to measure it accurately. So you have to do on the sagittal, vaginal ultrasound. You measure the thickest portion, and it is very important not to take the hypoechoic junctional zone. You only measure the echogenic part. And so why is that important? Because we use vaginal measurement to triage patients. Do they need a biopsy? Do they need, in postmenopausal women? In premenopausal women, the thickness of the endometrium can be very variable. But in postmenopausal women, it's really important to look at the thickness. So if the patient has vaginal bleeding, okay, we're concerned about endometrial cancer because the most common clinical manifestation of endometrial cancer is vaginal bleeding. So there are several measurements in the literature, 3 to 5 millimeters. So I use 4 because I want to be in the middle. But basically, there are many studies that have shown that if the endometrium, you can see it and you can measure it, and it's less than 3 to 5 millimeters, depending on who you read, the risk of endometrial cancer is extremely low. If the endometrium is thickened, in a patient with postmenopausal bleeding, there's a higher risk of endometrial cancer, 7.3%. This patient needs endometrial sampling. I just say histologic sampling because they can do it whichever way they want. In patients who are asymptomatic, postmenopausal women without vaginal bleeding, then, because the risk of cancer is less, then we go to about 10 to 11 millimeters. So, people ask patients on hormonal replacement therapies, on tamoxifen. As long as the patient is asymptomatic, it's generally accepted that you can go up to 10 millimeters before you recommend tissue sampling. So when I look at a thickened endometrium, what do I look at? I look at the echo texture. Is it homogeneous? Is it heterogeneous but with cystic changes? Or is it really heterogeneous without cystic changes? That's when I start to worry about endometrial cancer, particularly in a patient like this. And I think looking at the vascularity is also helpful. So why? Because we've already talked about the kind of stalk vessel, one vessel leading into the endometrial polyp. You also have a regular endometrial to myometrial junction. So what about this patient? So this is a case I actually misread. This was a younger woman. She was only 39. And there was not really a good history. So we said, okay, her endometrium's a little thick, but she's only 39. Everything else looks okay. And then, so this was, I didn't read, I read the one before that. Then she came back because she had a lot of vaginal waterway discharge. We had a repeat scan now, and when we looked a little bit more carefully, we put the color, and here there is absolutely disorganized vascularity. So that's not normal. There's also kind of, increased diastolic flow that you see in tumor vessels. And basically what this patient had is a Figo-type endometrial cancer. And it was caught still early, so she did okay. But I think I learned my lesson that always look very carefully at the vascularity. Always put the color box over the endometrium. Now, if you see something like this is a very, mildly enlarged uterus where you can't even see the endometrium. It's very heterogeneous, very disorganized vascularity. Again, this is the infiltrative appearance of endometrial cancer. So this patient will have an MR for staging, and then we have TASPSO, and she did have endometrioid cancer with myometrial as well as lower uterine segment invasion. Now, when you do not see the endometrium, you have to be very careful. There are several reasons, right? It can be obscured by a large fibroid or some other abnormality, adenomyosis, or it could be because it's atrophic, and some series, it's a significant number of patients, we don't really see the endometrium. But you always have to think about the possibility of infiltrative cancer. So if it's a postmenopausal woman with vaginal bleeding, I clearly say in my impression, I don't see the endometrium, recommend endometrial sampling, because if you look at this case, I mean, yes, the uterus is heterogeneous. I don't see the endometrium. I'm not sure why, but if I put the vascularity, then again, it's again disorganized vascularity. So I'm even more concerned. And this patient had carcinosarcoma at hysterectomy. So my take-home point is that both adenomyosis and myoma are common condition, and they can coexist, definitely. That endovaginal ultrasound is very accurate for the diagnosis of adenomyosis, but I highly recommend you do cineclips. Don't forget external adenomyosis. This is deep pelvic endometriosis. These patients are much more symptomatic. They need help, right? And I think Dr. Asher will talk about the unrecognized endometriosis, perhaps. Beware of the very large uterus in older women. Just be very generous in recommending an MRI. Beware of disorganized vascularity. And again, MR for difficult cases, cancer staging, and treatment planning. And with that, I thank you very much for your attention.